missed any class, you get that day off, so you get an extra long weekend. And then everyone will start clinical on next Wednesday, which is the 31st, and everyone will be getting there at 7 a.m. Like we talked about before, make sure review your syllabus for what to wear and what to bring with you. Any questions before we get started on our workbook? Nope. All right, then we will go ahead and get started on workbook chapters from yesterday. So starting out with chapter 15 on page 87. Starting with section 1, it's asking you to put the letter for the correct type of nutrient. Number 1 is P, number 2, W, 3, M, 4, F, 5, P, 6, F, 7, B, 8 and 9, C, 10, W, 11, F, 12, W, 13, V, 14, F, and 15, M. For section 2, labeling 1 through 5, number 1 should be vegetables, number 2, fruits, number 3, grains, 4, proteins, and 5 is the dairy. And then for number 6, as long as you filled that out for practice, you will be good to go. Starting on page 88, under multiple choice, number 7, B, 8, A, 9, C, 10, C, 11, D, 12, C, 13, D, and 14, B. And Melanie, I got you down. All right. Next section for section 3, fill in the blank. Number 1 is eat. Number 2, oral care or mouth care. Number 3, food. 4, beverages or drinks. 5, time. 6, utensils. 7, upright. 8, appetite. And 9, intake. Under the short answer questions, you should have a check mark next to number 11, number 12, number 14, and number 15. For section 4, for number 1, as long as you filled that out, you'll get credit. And for number 2, residents have the right to choose the food that they eat. They have the right to refuse food or drink, the right to request additional food, the right to choose where they sit to eat, and the right to choose whether or not they wear a clothing protector. Section 5, short answer number 1. The dietary department plans all of the meals for the residents. For number 2, different things that they consider would be nutritional needs, resident likes and dislikes, making sure meals are balanced to provide proper nutrition, making sure the food is manageable, and that it looks and smells appealing. For number 3, who wants to tell us what info we would find on a diet card? Yeah, Valerie?
I got special diets, allergies, likes and dislikes, and other dietary instructions.
Good. And also their name. Obviously, right? It's going to say who they are and then their special diet. Good. Thank you. And then on the next page, for section 6, all sorts of different types of diets. Matching question number 1 is J, 2 F, 3 Q, 4 A, 5 L, 6 M, 7 N, 8 B, 9 E, 10 D, 11 P, 12 G, 13 R, 14 H, 15 S, 16 I, 17 C, 18 O, and 19 K. Under section 7, true or false, number 1 is true. Number 2, 3, 4, and 5 are all false. Number 6, true. 7, false. And 8, true. And then for section 8, the crossword puzzle, for the across questions, number 1 is hands. Number 4, upright. Number 5, socializing. For the down questions, number 2, dentures. Number 3, assistive. And number 6, low. For the scenario number 7, who wants to tell us what they got? What can we do to help this resident? Yeah, Rebecca?
Tell them the clock mode.
Good.
Everything's up.
Yeah, so you could say, like, if we were looking at a clock face, your steak is at 6 o'clock, or your potatoes are at 8 o'clock, or what have you. So they can imagine on their plate where they would find that food. Thank you. For number 8, this resident, if he's coming to dinner in his pajamas, doesn't look like anyone has assisted him to get ready, we would want to encourage him to get dressed in his day clothes, maybe help him brush his hair, help him to brush his teeth, get his shoes on, wash his hands. So get him ready for mealtime. For number 9, we want to make sure that if we have other Spanish-speaking residents, we introduce her to them. Also want to make sure that we decrease the noise level. That way she has a better opportunity to hear and to understand. Ensure the dining room is warm enough also. If she's really cold, she's wrapped up in a large sweater. And if we need to, we can always get an interpreter so that we can better communicate with her. Next page, number 10. We would want to report the denture issues to the nurse so that those can be handled. If the resident is not able to eat with their dentures and they're causing pain, they're not going to be getting those nutrients. So very important. For section 9, multiple choice number 1 is A, and number 2, B. Under true or false, numbers 3, 4, and 5 are true. Number 6, false. 7 and 8, true. 9, 10, and 11, false. 12, true. 13 and 14, false. Under the scenario for number 15, we can just bow our head and be quiet while the resident prays. That is perfectly acceptable. For number 16, we want to be friendly. Remember, we never want to appear rushed. We also don't want to take personal issues out on residents. Remember, we leave our own issues at the door, and we should not ever be trying to engage those residents or take that out on them. For number 17, remember, we don't joke about residents. That's considered to be abusive behavior. We need to be positive and help this resident, also socialize with the resident. For number 18, we should check back if we deliver a meal tray. After we finish delivering them all, you should just peek your head in, make sure everyone's doing all right. They don't need something like silverware, condiments, seasoning, assistance with something. So try to check back in sooner. That way we can assist the resident if they need that assistance before their food gets cold. For number 19, if the diet doesn't look correct, you would report that to the nurse before you serve the tray. So consult with the nurse, make sure that the tray is correct for that resident before you drop it off. For number 20, we want to promote independence. So we want to allow the resident to do what they can, no matter how long it takes, as long as they're safe to do so. So even if it takes them twice as long to do the same task, as long as they're safe to do so and they can do it independently, we want to allow that to happen. For section 10, fill in the blank question 1 is assistive. Number 2, clock. On the next page, number 3, stronger. 4, tremors. 5, cue. 6, clear. 7, wheelchair. 8, open. And 9, swallow. For section 11, who wants to go through multiple choice 1 through 3? Yeah, Erica?
1B, 2A, 3D.
Good, thank you. And for section 12, true or false, 1 and 2 are true. 3 false. 4 true. And 5 false. Under conversions, have to do some math to come up with these ones. So remember the conversions that we looked at yesterday and the importance of knowing how to get between ounces and milliliters. And cups. Cups is important too. So if we start looking at number 6, says that the general recommendation for fluid intake is 64 ounces and is asking how many milliliters that would be. So if we multiplied our ounces by 30, because there's 30 mils per ounce, we would get 1,920 milliliters. And if we tried to convert to cups, that would be 8 cups. For number 7, it looks like we have 1 cup of liquid, 1 cup of orange juice, and it's asking how many milliliters of liquid this resident had. That would be 120 milliliters. For number 8, we have 6-ounce container of pudding. The resident ate all but about 35 milliliters. So it's asking how many milliliters total he ate. That would be 145 milliliters. For number 9, there's a bowl of soup that holds about 1.5 cups. 1.5 cups would be equal to 360 milliliters. And then at the top of the next page here, it says that she finished most of the soup, but there are still 25 milliliters left. So if we subtract that from the total we got, that gives us 335 milliliters that she ate. For number 10, we have a resident with some orange jello. He's given 1 cup of the Jell-O, but he only eats 1/4 of it. So that would leave him with a portion of Jell-O, and it is asking how much he actually ate. So not very much, only 60 milliliters. How much would be left over? Well, the rest of what would make up 1 cup, so that would be 180 milliliters. For number 11, this resident is going to use a urinal. It looks like he urinates 2 cups of urine. It's asking how many milliliters that would be. 2 cups equals 480 milliliters. And then for the multiple choice, number 12 would be C, number 13, A, 14, B, 15, A. For the labeling, remember we watched the video on measuring output. So we're looking at these containers eye level, and it's asking us to determine how many milliliters are in each container. So there's 2 ways that you can calculate this. The first way is you can look at the ounces, and then you can multiply the ounces by 30 to get the milliliters. Or if you look at the milliliters, you can try to determine where about the urine is. Some of these, it's easier to just calculate it based off of the ounces because you have an exact amount of ounces. So for example, on number 16, it looks like there are 16 ounces. If we multiply 16 ounces by 30, that's pretty easy. We get 480 milliliters. Whereas if you're trying to guess between 450 and 500 where that is, you may be a little bit off. For number 17, you can see on the ounces side, that is 21 ounces, so times 30 would be 630 milliliters. On the next page, for number 18, 120 milliliters. And for 19, 240 milliliters. And you'll get practice actually doing that in clinical and getting at eye level and looking at those containers as well. For section 13, true or false, number 1 is true. 2, false. 3, 4, 5, 6, and 7 are true. 8, false. And 9, true. Any questions from chapter 15? All right, moving on to chapter 16. Starting on page 97 with section 1. Multiple choice number 1 is C, 2, D, 3, A, 4, C. And then under short answer, you should have an X next to 5, 8, 10, 11, 12, 13, 14, and 15. Under section 2, numbers 1 and 2 are true, 3 false, 4 and 5 true, 6 false, 7 and 8 true. Next page, multiple choice. Who wants to tell us what they got for 9 through 13? Yeah, Samantha?
Okay, for 9, I got B, 10A, 11C, 12C, and 13A.
Good, thank you. And for section 3, number 1 is false, number 2 true, 3 false, 4 true, 5 false, 6, 7, 8, and 9 true, 10 false, 11 true, 12 false, and 13 true. For section 4, matching question 1 is E, 2A, 3D, 4B, and 5C. Short answer question 6. We want to make sure to keep the drainage bag below the level of the bladder. Keep it off the floor. Make sure the catheter tubing is not kinked. And make sure we keep the genital area clean to decrease the chance of infection. For number 7, things to report about a catheter. If there's any unusual characteristics to the urine. If the catheter bag either is not filling or fills suddenly. If the catheter comes out. If you're providing pericare and there's urine leaking from the perineal area around the catheter. If the resident reports any pain, pressure, discomfort. And also if you're emptying out the urine bag and the urine has any foul odor to it, we would want to report that as well. Under section 5, matching question 1E, 2C, 3F, 4A, 5B, and 6D. Section 6, multiple choice number 1, B, number 2, D, next page, number 3, C, 4, D, 5A. For section 7, for the scenario number 1, this nursing assistant does these things well. So they're remaining upbeat, positive, and friendly, and also not talking down to the resident about any incontinence. For number 2, this nursing assistant should do a few things differently in this situation. So instead of not really speaking to the resident, we should converse with them, right? This is the best time to get an idea of their well-being. We should make eye contact with the resident, and we should also not rush through. Remember, we're there to take care of the resident, so we need to take our time. For number 3, this nursing assistant is doing all of these things well, being encouraging and positive, charting the schedule, available to help and responding quickly to call outs, also complimenting the resident. Any questions from chapter 16? No? All right. Moving on to chapter 17. Starting with section 1 on page 101. Number 1 is true, 2 and 3 false, 4 and 5 true, 6 and 7 false. And for number 6, if you couldn't find the information on that one, iron supplements actually can cause the stool to be green. It's usually like a really dark green, almost looks black. And a lot of our older adults are on iron supplements or multivitamins, which could do that. For section 2, multiple choice number 1 is B, 2B, 3A, 4D, and 5B. For the crossword puzzle, it's my least favorite when they put it on 2 pages because it's really hard to go back and forth. So my recommendation for you would be to write your answer next to each part as well, if that helps you. So if you find number 6, you could write down diarrhea right there and then transpose it onto the next page. So 6 across is diarrhea. 8 across, hemorrhoids. Down, number 1 is caffeine. Number 2, ulceration. And number 3, colostomy. Then on to the next page, finishing up the down questions. Number 4 is upright. Number 5, fiber. And number 7 is GERD. Under section 4, short answer question 1, enemas are given to help eliminate stool. For number 2, who wants to tell us the proper position when a resident is receiving an enema? What is that called? Yeah, Irene?
Sims position.
Good, Sims position. Number 3, if the nursing assistant, or again, if your facility is allowing you to do this, or the nurse is doing it, the resident starts to feel pain, or there's any resistance to trying to put the fluid in, then we would stop. If you are doing it as the nursing assistant in your facility and you're allowed to do that, you would stop and report that to the nurse. If the nurse was doing it, you would stop the procedure, and then the nurse would assess the resident and figure out what's going on. For number 4, legal rights would be privacy. That includes keeping the resident covered, closing the door, pulling the curtain in a shared room, closing the blinds to the outside, and then also making sure that the resident has all of their questions answered. For section 5, number 1 is true, 2 false, 3 and 4 true. Section 6, fill in the blank. 1 is occult, and 2 is cancer, specifically colorectal cancer or colon cancer. Section 7, 1 and 2 are true, 3 is false, and 4 is true. For number 5, the resident might feel embarrassed because they've lost control of a basic bodily function. They're having to have someone else assist them to clean that up and to change their appliance. Multiple choice number 6 is C. Number 7, B. And then section 8, fill in the blank. Number 1, the first blank is routines, and the second is function. Number 2, gloves. Number 3, schedule, and then the second, record. Number 4, fluids and fiber. Number 5, privacy. Number 6, perennial or peri. Number 7, protectors and incontinence. Number 8, successes and attempts. And number 9, frustration and anger. Any questions from chapter 17? Yeah, Jeffrey? So high fiber food, if somebody is eating a correct amount of fiber in their diet, bowel movements are going to come through easier. If somebody eats something that is potentially an irritant, or they eat too much of one thing at one time, it can cause a blockage, especially for an ileostomy. Because an ileostomy, so if we have like the small intestine and then it connects to the large intestine, ileostomy is in the small intestine. So that food is not fully digested by the time it's coming out of that stoma. So sometimes for an ileostomy, there can be a blockage. If that food is not digested enough, or there is a large amount of that food, it can block that stoma site. Kind of like constipation, where stool is not coming out of the rectal area. Same thing for the stoma. So it can be caused by a lot of reasons. Most commonly, it's going to be something that they ate in abundance, or it's going to be a lack of fluid intake. So if there's not enough water to get that food moving around, kind of lubricating its passage through the tract, it can get blocked. Some residents who have an ileostomy, you'll see in their diet, they're to avoid certain foods because they have either had a blockage or come close to having a blockage due to that food. So it's not like a one size fits all for each resident, if that makes sense. There are some foods that are pretty common to block, and there are some things that some residents will eat that'll block at one time, and then the doctor's like, yeah, don't eat that again. Don't do that again. We don't want to have to go in and manually release your stoma. Good question. Any other questions? All right. Then we will put away the workbook and move on to today's content. So a couple of videos that I wanted to show you from the skills videos from yesterday and the day before, just regarding vital signs. So we'll watch a couple of those and then we'll get into chapter 18. So the first one is assisting with the use of a bedpan, and then we'll move on to pulse and respirations.
Hi, Ms. Bragg. My name is Betsy. I'm your nursing assistant today, and I understand you need to use the bedpan.
The candidate ensures privacy is provided with a curtain, screen, or door. Before placing the bedpan, the candidate ensures the head of the bed is in the lowest position. They then wash their hands prior to putting on clean gloves.
So I'm going to need you to bend your knees and lift your bum up off the bed.
A critical step, the bedpan is correctly placed under the candidate's buttocks. The candidate then removes and disposes of gloves into the waste container and washes their hands.
Sit you up a little bit.
After positioning the client on bedpan and removing gloves, the head of the bed is raised to a comfortable level for the client.
Is that comfortable? Mm-hmm. Okay. Here's your call light.
The candidate ensures toilet tissue is within reach and the hand wipe is within reach. The candidate instructs the client to clean their hands with hand wipe when finished. The candidate ensures a signaling device is within reach and instructs client to signal when finished. Before removing the bedpan, the candidate ensures the head of the bed is lowered to the lowest position. After the client finishes, the candidate washes their hands and puts on clean gloves before removing bedpan.
Is your knees again?
While avoiding overexposure of client, the bedpan is removed.
Yeah. Go ahead and relax.
The bedpan is then rinsed with the contents going into a bedside commode or toilet. The bedpan is not dried in this skill.
Do you want me to keep that clear on for me?
It is then placed into the designated dirty supply area. After placing the bedpan in designated dirty supply area, gloves are removed of without contaminating self into a waste container, and they wash their hands.
Make sure the bed's locked and low. Still got your call light. Open up the privacy curtain. Wash my hands, and the skill's complete.
So that was a regular bedpan. Any questions on that one? All right, then moving on to radial pulse.
Hi, Miss Bragg. My name is Betsy. I'm your nursing assistant today, and I need to take your pulse. Okay. First, let's make sure the bed is locked and low. Provide privacy. I'm going to wash my hands.
The candidate places their fingertips on thumb side of client's wrist to locate the radial pulse. They then count the beats for 1 full minute.
Okay, on the count of 3, we're going to start counting. 1, 2, 3. Okay, good. Okay. Okay. Thank you very much. Check to make sure the bed is locked and low.
After ensuring signaling device is within reach, and before recording, the candidate washes their hands.
Wash my hands.
A critical step. After obtaining pulse by palpating in radial artery, the candidate records the pulse rate within plus or minus 4 beats of the evaluator's reading.
Okay, wash my hands, and the skill's complete.
So as you can see, there is some wiggle room on your state exam. You don't have to be exactly on point, and you'll get plenty of practice on that in clinical. Another thing that I want you to notice when you are doing vital signs, especially for the purposes of your state exam, you will be counting the pulse and the respirations for a full 60 seconds. Once you finish your state exam and you move into working in a facility, follow your facility's policy. Some facilities will allow you to count for 30 seconds and multiply by 2, or count for 15 seconds and multiply by 4. So follow facility policy for that. For the purposes of your state exam, it'll be 1 full minute that you'll be counting. Moving on to respirations, remember when we talked about respirations, I said the only time that you want to tell someone you're checking their respirations is for your state exam. So you will notice that this nursing assistant tells the resident that they are checking their respiration.
Hi, Miss Bragg. My name is Betsy. I'm your nursing assistant today, and I need to check your respirations. Bed is locked. Bed is low. Provide privacy. Move this out of the way. Now, wash my hands.
The candidate counts respirations for 1 full minute.
1, 2, 3. Yep. Bed is locked. Bed is low. Open up the curtain. Here's your call light.
After ensuring signaling device is within reach, the candidate washes their hands. A critical step. The candidate records respiration rate within plus or minus 2 breaths of the evaluator's reading.
But wash my hands, and the skill's complete.
All right. I saw a hand up. Did somebody have a question?
No, sorry, I pushed it on accident.
Oh, okay. No worries. And then, yeah, Melanie, did you have a question?
I did. It was about the first video with the bedpan.
Mhm.
The resident will wipe themselves, correct?
It depends on their abilities.
Yeah.
You'll see in their care plan what their abilities are. So if they can wipe themselves, yes. If not, then we would be doing that as well.
And as far as them wiping themselves, sometimes it's recommended, at least for females, to wipe from front to back. But when you have a bedpan and you're in bed, I feel like it would be a bit more complicated. So oftentimes I'm assuming the resident will ask us, like, how should I do it? Or how can we kind of like navigate that?
So yes, we want to wipe from front to back regardless of where they are.
Mhm.
So if we need to, we can always turn them on their side and then assist them to wipe from front to back. Usually when a resident is able to do the care themselves, we would just remind them, don't forget, to prevent a urinary tract infection, you want to make sure that you're wiping from the front to the back. Just give them that little reminder so that they know how to do that as well. Yeah, so we have to sometimes reposition them to be able to fully get that area clean and dry. Because if we can't do it adequately where they are, we need to figure out some way to get it cleaned adequately. Otherwise, they're at risk for skin breakdown, being kind of stinky if we don't get all of the urine or feces off of their skin as well. So we have to kind of work with whatever the situation is at hand. Any other questions? All right, the last one is blood pressure. If I can find it, there we go. So this video will show you one way to check blood pressure. I just want you to see how the process works. And then in clinical, you will also get to see how to check the blood pressure. You'll get to watch another video and you'll get to practice. So don't worry too much if you're like, oh gosh, what did they do first, second, third? You don't need to know that. Just want you to see how it's done.
Hi, Miss Bragg. My name is Betsy. I'm your nursing assistant today, and I need to get your blood pressure. Okay. Wash my hands. Check to make sure the bed is locked below. Provide privacy. Wash my hands.
The client's arm is positioned with palm up and upper arm exposed. The candidate feels for the brachial artery on the inner aspect of the arm at the bend of the elbow. Before using stethoscope, wipes bell and diaphragm, as well as the earpieces of the stethoscope with alcohol. The candidate places blood pressure cuff snugly on client's upper arm with sensor or indicator arrow over brachial artery site. The earpieces of the stethoscope are in ears and bell or diaphragm is over brachial artery site. The candidate inflates the cuff between 160 to 180 milligrams of mercury. If a beat is heard immediately upon cuff deflation, completely deflate cuff. The cuff is then reinflated to no more than 200 millimeters of mercury. This is critical as it would be considered a safety stop. Deflating the cuff slowly, candidate notes the first sound and last sound. If needed, measurements are rounded up to the nearest second millimeter of mercury. The cuff is removed. Before recording, the candidate washes their hands. A critical step, after obtaining reading using blood pressure cuff and stethoscope, records both systolic and diastolic pressures, each within plus or minus 8 millimeters of mercury of evaluator's reading.
Lock below. The curtain.
The signaling device is given to the client.
Would wash my hands, and this goes complete.
All right. Those were the ones I wanted to show you for today. Now we will get started on our chapters for today. So starting out with chapter 18. Chapter 18 is going to go over a lot of different conditions that you might see when you're working in a healthcare setting. We go through a lot of conditions. We won't go through each of them extremely in depth, you will come across various different medical conditions depending on where you work. So a lot of times with these, it's like learn as you go. So maybe you've heard of it before, but then the first time you see it, you'll be able to connect the dots. Like, oh yeah, I remember learning about this, and now this is what it looks like, and you can better understand it that way. So starting with chapter 18, and we're looking at different conditions that are classified under two different categories, acute and chronic. So when we talk about a medical condition being acute, it is something that typically comes on quickly, doesn't last very long, and is able to be treated and resolved pretty immediately. Whereas something chronic is a disease or condition that is long-lasting. So it doesn't get cured or resolved. Instead, what happens is it remains with that person for the duration of their life. And in the meantime, so while they are going about their day-to-day life, their symptoms are being managed, usually with different sorts of treatments. So many of the conditions that we see as diagnoses in our residents' care plans are chronic illnesses. These are things like heart disease, diabetes, kidney disease, whereas something acute might be like an infection, like a UTI, or some sort of respiratory infection. So you will see those diagnoses split up into those two categories. We'll go through all of these things as we look at the actual section, so we'll skip over the definitions. Scabies, I'll show you a picture of what it looks like. Scabies is a highly contagious little rash that's actually caused by mites burrowing underneath the skin. Scabies spreads really quickly in a facility, especially because we have a lot of people in close contact with one another. Signs and symptoms are intense itching, and there's a very characteristic appearance to the rash. For scabies, the only way to treat it is with medicated topical, like a cream or lotion, as well as a medication taken orally so that it can be systemically fought as well. So the scabies rash looks something like this. So you can see in this first picture, can you see there's like a little tract under the skin? It's kind of raised. So that would be where the little mite is burrowing underneath the skin. And then there's little scabs along there. That is characteristic of a scabies rash, and that is what causes that intense itching. So those little mites traveling around underneath the skin. Scabies, the first time that I ever saw scabies was on a patient that came into the primary care clinic I worked in. And when that patient came in, based on their report from their appointment notes, when they signed up for their appointment, the reason they were coming in, we didn't suspect that they had scabies. They didn't really describe any intense itching or rash. They just said that they had a new rash. So they came in with this new rash, and the doctor saw them, and the doctor was like, yep, that's scabies. And protocol in our facility was we actually had to close down the entire room for 24 hours. And the housekeeping team came in and disinfected that entire room. So again, highly contagious, something that spreads really quickly in a facility. That's why it's so important that if you see something and you're not sure what it is, but it's something new, that you get it reported to the nurse. Moving on to our next skin disorder. Shingles is what it's referred to as. Shingles is actually caused by what's called the varicella-zoster virus, aka the chickenpox virus. Anyone who previously had chickenpox, usually during childhood, is at risk for developing shingles later in adulthood. Signs and symptoms of a shingles rash would be intense pain, especially tingling and itching, that is then followed by a rash. So the pain, tingling, and itching start before the rash actually appears. Like I said, if you have had chickenpox during usually childhood, as you get older, your likelihood of getting the shingles is increased. One thing to know with shingles is that somebody who has shingles cannot transmit shingles to another person. They can transmit from their shingles rash chickenpox, because it's the same virus, to someone who is either unvaccinated or who has never had chickenpox. So, piece of advice there, if you've never been vaccinated for chickenpox and you've never had chickenpox, please be very cautious if you are taking care of a resident that has an active shingles rash. Shingles is treated with medications. A lot of times, one of the main treatments for the symptoms that are caused by shingles is pain medication. It's really painful to have a shingles rash. Also, there is a preventative measure. We've had a shingles vaccine around for quite a while. The first shingles vaccine that was introduced was not as effective as we had hoped. So there's actually a newer vaccine within the last 4 or 5 years called Shingrix, which is proving to be more effective. It also has a broader range of people that can receive it, including anyone who's already had shingles. So then hopefully they don't get it again in the future. So that Shingrix vaccine, if the resident has had chickenpox in the past, they typically would qualify for that. It's a 2-dose vaccination series, and then that helps to protect them from getting shingles again in the future. So what does shingles look like? It depends on its location for its exact appearance. A lot of the times it will happen on people's face. That can be really painful. It also tends to happen, for example, on the abdomen. So I'll show you a picture of it on the abdomen. No, we don't want that. So you can see, like I said, the rash comes after the intense pain and itching start. So you may not be able to tell what's going on. You're just having pain and itching in an area, and then it suddenly gets this rashy appearance. It usually occurs on one side, so it's not usually going to be like on the left and the right. It's usually just on one side. Again, most common report with this is pain, and there's usually no reason for the pain. Somebody will usually go into the doctor and say, I'm having pain here and I don't know why I'm having pain here. And that's typically before that rash starts. Wounds, we already talked about, so we won't go through those again. If you want to brush up on those, you can look back through the previous chapters. Dermatitis is a very general term. Dermatitis essentially means swelling or inflammation of the skin. There are some specific types of dermatitis. Usually we would see this as a medical diagnosis for the residents. And these are things that don't just happen once and go away. These are things that they typically would have either consistently or maybe things that come and go for them. So one of those is called atopic dermatitis. Atopic dermatitis refers to eczema, if you've ever heard of the term eczema, which a lot of times happens with allergies, especially in younger kids. It can be worsened by stress. Usually what happens with atopic dermatitis or eczema is that the skin becomes really dry, itchy, and inflamed. Usually occurs on the limbs and also on the cheeks. One good thing about atopic dermatitis is that it is not contagious. So if you touch someone's skin that has this, it's not going to be transmitted to you. Typically, during an outbreak of atopic dermatitis, a resident will be treated either with antihistamines to help with the allergy component or with special topical lotions to help with the irritation of the skin. Another type of dermatitis that we see usually in the older population is called stasis dermatitis. Stasis dermatitis commonly affects the lower legs and the ankles. It's a result of fluid buildup under the tissue. So we talked about edema. It can lead to a lot of issues with the skin, also with the vasculature, the circulatory system in that area. What you would normally see if somebody has stasis dermatitis is a rashy red area. It's usually itchy. Also, chronic swelling or edema of the lower legs. Typically, the skin looks tight and smooth or shiny, like we talked about yesterday. With chronic stasis dermatitis, meaning that someone has had this for a while, you may also see darkening to the lower legs, so the tissue may turn darker color. Typically, stasis dermatitis, since it is interrupting the flow of blood, can also cause pain. So if your resident reports pain, that could be one cause of it. So let's look at some pictures of eczema and stasis dermatitis. So here is a picture of a baby with some eczema on their face. Like I said, with eczema, a lot of times in children, it's related to an allergen. A little boy that I previously took care of had really bad eczema on his cheeks and both of his arms and legs. And usually where the doctors start trying to rule out causes is with foods for children. And so the first thing that they ruled out was eggs. So the child didn't eat eggs for a period of time to see if the eczema would go away. That was not the issue. So the second thing that they tried was cow's milk. So the child was not allowed to have anything with cow's milk in it. Instead, they used like an alternate milk. I think they went with hemp milk, if I remember correctly. And they give that a couple weeks and see if that resolves it, and that worked. So there was something in the milk that was causing the child to have this allergic reaction, which was in the form of eczema or the rash on the skin. And then more common in our older adults, stasis dermatitis. Again, typically going to see this in the lower legs. And characteristic appearance would be something like this. See if it will zoom in. There we go. Something like that. So you can kind of see it looks irritated. It looks a little swollen, inflamed. Looks like it might have had some scratching occur, especially on the left side there. That would be like an early stasis dermatitis. The longer it's present and the more itching that occurs, can also start to develop wounds as a result of poor circulation, fluid buildup, and also interrupting the skin. So that can lead to further issues. Yeah, Valerie?
Can swollen or like enlarged veins be from other conditions too?
Yes. Yes. So the reason that the vessels swell for someone who has stasis dermatitis is because of that fluid buildup. Vessels can swell for other reasons as well. Yeah. Sometimes you can't determine a cause for that, but sometimes it's related to insufficiencies in the actual circulatory system. Sometimes it's fluid buildup. Sometimes it's damage to the vessels. So lots of different reasons that can occur. So for stasis dermatitis, the best method of getting rid of this or helping to keep it at bay is to take a medication that's going to decrease the buildup of fluid. So typically with stasis dermatitis, there's some sort of circulatory issue that is causing that fluid buildup. So if we can give, or the nurse can give a medication to the resident to help get that fluid off, then that can help to resolve those issues. Another thing that we could do, which we will get to watch a video on, is apply what are called anti-embolic or TED hose stockings. Those help to promote venous return, so promoting the blood flow and additional fluid to return back up to the heart and to be redistributed. With someone who has stasis dermatitis, like I said, a lot of times it's a circulatory issue. If there is a circulatory issue, they may be on a heart healthy or low sodium diet for that as well. Like I said, there are a lot of other causes. Sometimes someone doesn't have a circulatory issue and they get what are called varicose veins. Varicose veins can be repaired surgically. What happens with a varicose vein, and if you have never seen it before, I'll pull up a picture. Here we go. So what happens with a varicose vein is that the veins become enlarged. They get really close to the skin surface and they start to kind of twist up. So that's what the bulging appearance is from. So here is a picture of varicose veins. They're also called spider veins, if you've ever heard that term. Maybe if this wants to load. Come on. There we go. So you can see in the back of this person's leg, kind of some wavy looking areas. That would be an example of a varicose vein. They also tend to be more pigmented, more color is present because they're closer to the surface of the skin. All right, moving on to infections. So we talked about fungus when we talked about infection prevention. Fungal infections, as far as those that occur on the body, what happens is that there's an imbalance of the normal fungi that we have. So we normally have fungi on and in our body. Once that fungi gets out of balance is when we get a fungal infection. So typically fungal infections are things like athlete's foot, vaginal yeast infections, jock itch. There are other sorts of fungal infections that can take place inside of our system as well. We won't talk too much about those. One thing that can put someone at risk for a fungal infection is if they have some sort of weakened immune system. So our older adults, right? Immune system doesn't function as properly. Or if they're taking some sort of medication like we talked about yesterday to suppress their immune system due to what's called an autoimmune condition. Antibiotics have a lovely way of wiping out our good bacteria in addition to any bad bacteria. So a lot of times when a resident is taking antibiotics, they then can develop a fungal infection. Treatment, usually topical, applied directly to the area. We have antifungals that are in the form of like a cream or ointment applied directly to the skin. There are antifungals that can be swished around in the mouth if there's a fungal infection there. Fungal medications that can be inserted into the vagina if there is a vaginal yeast infection. Also medications that can be injected. So it kind of depends on the location and the severity. Questions about any of those skin disorders? All right. Moving on then to musculoskeletal disorders. Arthritis is a really common one that you'll see in the older population. What happens when someone has arthritis is the joint spaces become inflamed, they get stiff, and they become painful. That can lead to a decrease in the mobility of the resident. When we look at different types of arthritis, each type of arthritis is a little bit different. So it kind of depends on what actually causes it for how it's going to appear. For example, when we look at osteoarthritis, oops, where did we go? There we go. Osteoarthritis. Osteoarthritis, osteo meaning bone, and then arthritis meaning inflammation of the joints. So it typically affects the areas like knees, hips, fingers especially. It's also called degenerative joint disease. So this would be the most common form of arthritis in our older adults. We also have a form of arthritis that is autoimmune in nature. So kind of similar to how we talked about Crohn's disease, the immune system attacking the GI tract. Rheumatoid arthritis, the immune system is attacking the joints. So rheumatoid arthritis is also abbreviated RA. And with RA, the immune system attacks those joints, and those joint spaces become inflamed. They can often appear red, swollen, really painful for residents. They can also result in deformities. So a common deformity for rheumatoid arthritis is in the hands. I took care of a lady in the Jerry Psych facility, and she actually did not have any diagnosis that would require her to be there. She didn't have dementia. But what she had was severe rheumatoid arthritis that had affected her hands, and her hands looked very similar to this. So you can see the picture on the left is an x-ray of the hands, and then the picture on the right would be the actual hands. So the severe deformity to those joint spaces makes it really difficult for these residents to be able to do anything for themselves. Something as simple as picking up a cup or buttoning up their pants, they can't do when their joints become this inflamed and deformed. So arthritis is a chronic condition. Things that can be done to help with arthritis. There are different medications that can help with swelling. Heat helps with arthritis. Range of motion exercises, which we'll talk about tomorrow. Being mobile, getting up and taking a walk. Exercise helps to move those joint spaces and keep the bones and joint spaces lubricated. And there are also some dietary factors that can come into play as well. So what we can do for our older adults who are experiencing arthritis, keep in mind during the colder months of the year is when the symptoms tend to be most prominent. So applying a heat, warm compress, helping them to go around and exercise, encouraging that activity, taking a walk with them, making sure that if they do have any deformities, they have clothing that is easy to put on. They may need adaptive utensils, so helping them with that. Also encouraging, again, their independence, right? Anything that they can do for themselves safely, we want to promote their ability to do that. Osteoporosis is another condition of the musculoskeletal system. What happens with osteoporosis is the bones lose density, therefore they become brittle, and it is very easy for them to break or to have a fracture. What causes osteoporosis most commonly is postmenopausal women's lack of estrogen, so one of the hormones. Other things that can contribute, not enough calcium in the diet, lack of regular exercise or mobility. Also, chances of osteoporosis increase as we get older. Signs that someone has osteoporosis. A lot of times low back pain will start to occur. More common fractures, so even from something as simple as just like maybe a little trip over something and falling down can cause a fracture, whereas for a resident whose bones were not brittle, that fracture probably wouldn't happen. Becoming a little bit shorter over time and also having a stooped posture can occur when someone has osteoporosis. So what the bones actually look like when they are healthy versus when they have osteoporosis. Look at this picture, just to give you an idea. So the picture on the left would be normal bone composition. Picture on the right would be somebody's bones that have osteoporosis. So you can see that density really starts to go away. So less dense bones, more likelihood that they're going to have a fracture. For osteoporosis, you've probably seen commercials on the TV for postmenopausal osteoporosis. There's actually an injection that can be done to help to prevent fractures and to help to try to maintain some bone density. Other things, staying active, just simply going for a walk, being very careful if you are taking care of a resident who has osteoporosis. Usually they are going to be on fall precautions. And knowing that some residents who have osteoporosis may be taking medications and supplements to help with that bone density. So there are side effects to all medications and supplements. And of course, if we notice any potential side effect of a medication, we would report that to the nurse. Fractures, usually in a facility, what we would see with a fracture would be called a closed fracture. So that's where the bone breaks, but it doesn't actually protrude through the skin. An open fracture would be more of like a traumatic injury, something like a motor vehicle accident. So with an open fracture, the bone actually does penetrate or protrude through the skin. Open fractures can also be called compound fractures. If you've ever had a fracture, think about what type it was. Did it come through the skin or not? If you've never had the pleasure of seeing an open fracture, it's not something that I would recommend. I never desired to see bones outside of the body, but it happens. Sometimes they come through the skin. It's not a pleasant sight. A lot of times it's kind of shocking, like, oh my gosh, that's a bone sticking out. So like I said, usually not something you would see in a facility. Typically, if a resident falls, they're going to have a closed fracture, but something that you may see if you come across some sort of motor vehicle accident or some sort of traumatic injury that someone has. You might see that. So preventing a fracture in a facility, we already talked about. Fall prevention is the key to fracture prevention. The elderly, keep in mind, they heal slowly, right? All of their systems have slowed down. Healing is not something that occurs quickly. So preventing them, protecting them from those falls is really important. As far as cast care goes, follow the instructions in the care plan. If somebody has a cast, you will have instructions as far as how to care for the cast, what sorts of activities the resident should avoid, also what to observe for, like any changes to the skin, bleeding, discoloration, numbness, tingling, pain, drainage, etc. Casts are always to be kept dry, so keep in mind if you're doing a shower or a bath, we need to apply something over the cast to keep it dry. Usually your facility will have cast covers that are waterproof for that, so make sure you know where those are and how to use them. When someone has a cast on the lower limbs, they're going to have a weight-bearing status, and that will be indicated in the care plan as well. What that means is how much of their body weight they can apply to the area that is casted. So if they are what we call partial weight bearing, they're able to support some of their body weight on the affected leg. If they're non-weight bearing, they're able to support none of their body weight, and they should not even be putting that cast on the floor. So that cast should be held up in the air at all times. Once they progress to a status where the limb is healed, they will be moved over to a full weight-bearing status, so they're able to support 100% of their body weight on both of their legs. Looking at hip replacements, number one reason that someone would need a hip replacement in a facility is a fall. So if someone falls and breaks their hip, again, postmenopausal women, osteoporosis is a huge risk. Falling leads to a fracture. That's the most common cause of a hip fracture and need for a replacement in a facility. So the bones become more brittle, more porous, higher likelihood of falls. Bones heal very slowly. And also another thing to keep in mind with our older adults is if they do have a fall that requires a hip fracture results in a hip fracture, which would require a hip replacement, right? They would have to be hospitalized, right? They have to go into the hospital, they would need x-rays, they would need surgery. They're also at an increased risk for what we call a secondary illness. So as a result of the fracture, the hospital stay, and being immobile, they're now at risk for developing another infection, another issue like pneumonia, urinary tract infection. So those sorts of things are common. They commonly occur in our older population. As they go into the hospital for something, they're more likely to get something else while they're there. Like I said, hip fractures typically in our older population are a result of a fall, which then requires surgery to replace that hip. They can also be due to worn out joints, painful stiff hips as residents get older. So they don't only occur as a result of a fall. If a resident does have a hip replacement, the recovery for a hip replacement is not quick. Usually they're on different measures for 6, 8, 10, sometimes 12 weeks. That's multiple months. When someone has a hip replacement, they're typically sent home with what's called an abduction pillow. So it's almost like a wedge that attaches to both of their legs, and it keeps that hip in the proper position so that it doesn't get turned inward, outward, rotated. It has to be kept in a position that is no more than 90 degrees of flexion. So that wedge, that abduction pillow, helps to keep it in place. Residents who have had a hip replacement are usually non-weight bearing. They will then progress typically to partial weight bearing before they become full weight bearing. Range of motion exercises need to be performed, but they are never performed on the hip replacement side for obvious reasons, right? That hip needs to be kept in a certain position. Transfers, the hip replacement side needs to be kept straight, so that leg should not be bent, turned, pivoted. Nothing should occur from that leg. So a lot of times when we're transferring a resident who has had a hip replacement, more than one body is good. So if you can get some assistance. Things to observe and to report to the nurse. Any issues with the incision, drainage, bleeding, redness, pain, tingling or numbness. If there is any tenderness or swelling on the lower leg or the calf, especially after some sort of surgical procedure. If there is swelling, tenderness, or pain on one calf and not the other following surgery, usually means that there is some form of blood clot. So if you see that, report that to the nurse so that they can further assess. Also, and this is not only from your book, but also from personal experience, if a resident is not following their care plan instructions for allowing their hip to heal, please report that to the nurse. So we had a resident who came in following a hip replacement surgery who had dementia, came into the geri-psych facility, and this resident had earlier stages of dementia still was pretty with it, able to understand instructions, knew who she was, knew where she was, knew that she had had a hip replacement. And she didn't want to follow the instructions. She didn't believe that she needed to keep on her abduction pillow and that she couldn't walk. So she would take the pillow off and she would get up and try to walk. And so we would report that every time to the nurse. And one time she got up and she tried to walk, and she walked back over to her bed and she was in a lot of pain. She actually dislocated the hip replacement. So guess what? She got to go back in and have another surgery. So making sure that if you notice the resident's not following those instructions, if that hip gets moved out of its position, that you report that to the nurse, because ultimately it could require another procedure. Other things to report, any of the other issues that we've talked about, appetite issues, abnormal vital signs, if there is any issue with equipment that is being used, something is not functioning properly, you don't know how to use it, you would want to report all of that to the nurse. Any questions so far with the musculoskeletal system? All right. We'll move on to knee replacements and then we'll come back to those terms that were just on your screen. Knee replacements, a lot faster recovery than a hip replacement. Usually with a knee replacement, the resident is up and walking on the knee replacement same day. So knee replacements, why would we need this? If the structures inside of our knee get worn out, if there was some sort of injury maybe to the knee, if there is an issue with the knee while the resident is walking, sometimes the knees will buckle or give out. They're unstable. There are a lot of different structures in our knee that have to work all together to maintain the function of the knee. If one of those structures becomes damaged, then the entire knee is going to suffer. So that could require surgery. After someone has had a knee replacement, like I said, there's not going to be that specific positioning that's required like there is with a hip replacement. So they're usually able to get up and move around, to walk on that knee. They're going to require exercises like range of motion. They're going to typically be doing ankle pumps, so pumping their heel, their foot back and forth, getting that blood flow going. They may have compression socks or TED hose ordered. They may be in what's called a CPM, continuous passive motion device. It helps to continue to move that knee joint after replacement. And again, like I said, with hip replacements, if they have one-sided, meaning just on one calf and not the other, pain, tenderness, swelling, that would be something to report to the nurse because it could indicate a blood clot. Muscular dystrophy, I would say less common than some of these other things we've been talking about. MD is progressive disease. What happens with MD is that the muscles become weak, which leads to physical disability. MD is inherited, meaning it is genetic. It is something that you get from your family. With the weakening of the muscles actually start to waste away or atrophy, which leads to actual physical deformities. Most forms of MD are present at birth. Again, they're passed down in inherited in terms of genetics, so they are coming from someone else who has been impacted by the condition. When we are taking care of someone who has MD, we need to base our care on their abilities. They may need assistance with ADLs, range of motion, providing proper skin care and repositioning. ALS is another one. ALS, again, not as common as some of these other conditions. ALS is another progressive disease, so progressive meaning that there is no cure and it eventually leads to death. Can be diagnosed at any age. Usually from the time of diagnosis, the person has about between 2 and 5 years before death occurs. What happens with ALS is the respiratory control center actually becomes impaired. So that can lead to needing a breathing tube, not being able to breathe on their own, also needing a feeding tube, not being able to chew and swallow food on their own. A lot of support goes into caring for someone with ALS. So medication, physical therapy, occupational therapy, nutritional support, respiratory support, until ultimately death occurs. So unfortunately, MD and ALS are not things that can be cured. Moving on to amputations. So an amputation, when someone says that they have had their leg amputated, that means that it has been surgically removed. So amputations can occur in any part of the body. Typically, we'll see like the lower leg, so usually called a below the knee amputation. If someone has had an amputation, they may have what is called a phantom sensation or phantom limb pain. What I want you to know about these things is that they are to be taken seriously, just like if a resident reported average everyday pain. So phantom limb pain or a sensation occurs when part of the body has been amputated, but the nerve routes for that specific area are still present and are still sending messages to the brain saying, for example, that there is pain in a part of the leg that was amputated that is no longer there. So let's say, for example, I had an amputation below the knee on my right leg. So I don't have a right calf, I don't have an ankle, a foot, or toes. And let's say one day I said to you, you know, my right foot is really hurting me today. And you're probably thinking, you don't have a right foot, right? It was amputated. So what we would call that is phantom limb pain. And we would still report that pain to the nurse, just like if it was any other pain that was being reported in a body part that was present. So again, when a resident is giving us subjective information, we take their word for whatever the subjective information is. We pass that on to the nurse. So it is to be treated very seriously, just like pain. When we're caring for someone who's had an amputation, that initial process of adjusting from having the limb to not having the limb can be really hard on the residents. So we need to be supportive, assist them with ADLs, assist them with repositioning, maybe with range of motion exercises. Of course, taking that phantom limb pain very seriously and reporting it to the nurse. And we'll talk more about different types of prosthetics and also caring for the stump between the skin and the prosthetic when we get into rehabilitation tomorrow. Things in general to think about with the musculoskeletal system is some residents maybe have, had a knee replacement, or they have had a fracture, or they have arthritis. Some residents take your average everyday medication or supplement provided by the doctor. Some residents seek out other complementary practices or alternative practices like chiropractic, massage, acupuncture. There are different herbs and dietary supplements that can be taken to help with certain conditions, different homeopathic measures that can be taken. And what's really important to know is that no matter what your experience or your point of view is on these treatments, we would never try to sway a resident's decision. So if a resident wants to go get acupuncture and they feel like that helps them with their pain, great, we're going to allow them to do that. We're going to be non-judgmental. Sometimes those practices are combined. So resident takes the prescription medications from the doctor and then also seeks out something like massage therapy. So they can be combined as well. Any questions on any of those conditions from the musculoskeletal system? No? All right. We'll go ahead and take our first break, and then we'll come back and start on the nervous system. So turn off your microphone and your camera, and I will see you back in 15 minutes.